Thank you for having me. That was a very thorough introduction and does basically cover most of my present roles. And it's always been a place that is endeared to me, having had my first job at Mount Sinai. I worked there for 6 years and actually started an ergonomics program there and worked closely with occupational medicine back then. So it's fun to always come back and do this and hopefully help some people. So what I was going to do today is really just give you an idea of what you might provide to a PT or a PT practice to help them help, somebody with chronic low back pain. And as you know, 12 weeks, 3 months, and I would even say recurrent low back pain is chronic with what we know about pain science. And I'll get into that a little bit more, the pain science. But a recurrence to me really shows probably a connection to chronicity and some of the risk factors. So don't, even though it might be a new episode or case, if you know this person has had several back injuries at work, it probably is more of a chronic presentation. And we know these are some of the factors that increase that chronic pain or the pain with chronic low back pain. So just certain behaviors, right? I think if you do this long enough clinically, you can see that in persons as you first meet them, sort of possibly a history of anxiety and depression and their work, right? Their work, if more laborious, going to be probably more back injury. Nursing is another good example. Raphael brought up construction, obviously, probably two of the common areas of work here in Manhattan that you'll have people injure their backs, and unfortunately, sort of connected to chronicity. And then if it is a compensation case, unfortunately, I summarize this as it's a side of the fence scenario, right? They have to be injured to get the compensation and vice versa. So it almost feeds a certain presentation. The diagnosis can really play a big role, right? Treatment, workup, imaging. We know many of the imaging techniques and the findings on imaging techniques might not always be related to the presentation of that back pain. So sometimes that sort of confounds things, and people connect to that imaging as a cause effect and a definitive presentation, where we as clinicians, we know that's not always the case. And maybe certain emotions are connected to chronicity and a bad relationship with coworkers and supervisors, and even family can play a role in feeding chronicity presentations. So these and more can all be factors that increase that pain in a chronic low back pain. And the flags are definitely, these really get into some of those behaviors, right? That pain catastrophizing effect that certain persons can have, fear avoidance, connecting sort of movement to pain. So that only makes it more chronic, because as they sit on the couch, they're going to just make things worse. They need to move. They need to get that message pretty quickly to them, even though they might be in some pain. And failure of multiple treatment modalities is definitely a flag for chronicity. And why? Well, when it gets chronic, it might not just be physical. It might be brain-centered pain generation. Obviously, opioids have been a part of the first pandemic, as I call it, here in the U.S. and definitely was fed by the COVID pandemic. So opioid misuse definitely plays a role for these populations. And obviously, like I said before, a history of anxiety and depression can also definitely be a flag as to a risk of chronicity in the future. So my learning objectives here was really determine the proper client information to provide the physical therapist as best you can. Obviously, since it's a comp case, it's going to be inherent, but especially if you're referring outside of Sinai, they might not have access to your EMR. And these pieces of information might really help PT sort of understand their role. Determine the proper physical therapy evaluations that the PT should be using on somebody who's presenting with chronic low back pain. Like any other profession, I don't think all professionals understand the idea of chronic back pain. So be sure maybe when you see the evaluation done by certain practices that they definitely include certain things. And then probably most importantly, determine the appropriate proper physical therapy interventions and what the plan of care should look like for that chronic low back pain patient. So I think these pieces, and we can open this up to discussion during questions, are probably very important to have the PT get before the patient even visits the office. So what is that date of onset, right? When you work within this area of back pain and chronicity, you know that timeline of 12 weeks, 3 months, it's sort of cemented into your head. So knowing they're close or past it really will help the PT, I think, determine or look at certain things possibly with a little different path in the clinical pathway. The patient's job title and functional requirements, if you have them, a functional job description would be great too, but the PT can always go to ONET with just the job title. So that's a federal sort of job description. Prior PT, did they have it? Where was it? Maybe, the address and name of the company might give you some indications of things that might not have been done favorably or should be done again, right? Delayed recovery, is it being addressed psychologically? And obviously, with workers' comp case, this can be a tricky area. But I hope you get a little bit better understanding today of pain science and its importance. And I recently became certified in a pain science entity. So it really was strikingly eye-opening and definitely helpful. I think some of the tools that they give from a psychological, it was taught by psychologists and social workers. So some of the work I cannot do by licensing, but very, very, very useful information. Is partial duty available, or is return to work only full duty? Definitely can be an obstacle. Obviously, the sooner you get somebody back to work, the sooner they're going to feel better. So that's important. And if they do have partial duty, really, really powerful tool to be able to use. But if the return to work is only full duty, need to know that information too. and any contraindications there might be to active interventions, cardiac disease, things of that nature that might limit what you can do, or what limits you could bring that particular patient to at a cardiovascular level. And then if you do any of the questionnaires, say an oswestry or a fear avoidance, what is the score that you might have had the patient score, because that might be a week or two ago. And obviously, if we do it again, we probably want to hopefully see the score not going up or maybe even lessening now that they know that they're addressing the low back pain. And here's that ONET, the Occupational Information Network. It is a database by via the Dictionary of Occupational Titles. So could be very helpful, and you might even tell the PTs they might not be aware of this, that they could get a job description off of ONET. So what should be done when that chronic low back patient comes into the PT clinic? Well, the tools should involve some of these, a combination of these, depending upon, again, the patient presentation and or history and or their functional job requirements. So the fear avoidance belief questionnaire, Tampa scale of kinesiophobia, pain catastrophizing scale, probably one of those three should be administered to the patient, and often can be done prior to the patient even getting to the office electronically or emailed, and they can have had it filled out and hand in rather than having to get there a little bit more early to fill it out. Depression questionnaires, but one of those if we feel there's a history and or a presentation actively going on. And then the oswestry is definitely the most objective functional questionnaire connected to low back pain. So that should probably be in the picture. Any communication via the EMR would be very helpful to the PT if they are within your network. And then the physical therapist should definitely be testing trunk strength endurance. And I'll go over a couple of those tests. Functional testing, if they have to lift, piles is obviously a great, simple tool to do. Doesn't take much. Most clinics have everything that you might need to do a piles, and at least it's some objective information if the person has to lift at work. And definitely aerobic testing, a baseline. If you could connect it to function, that'd be great. So having the person meet a target heart rate, 65%, 80%, somewhere in that range of their maximum heart rate. And if you know they're going to walk a lot at their work, I would want the PT to connect to that dot, meaning get the aerobic test on, say, a treadmill in that case. So here are some of the questionnaires, right? This is the fear avoidance belief questionnaire. If you're not familiar, definitely not that involved, just 21 questions. So it can, I should say 16 questions, excuse me, but it can be, it could be done within about 10 minutes. So it is definitely one of three that should be done. This is that Tampa scale for kinesiophobia. Again, not too lengthy, but and pretty simple and straightforward. They just pick one, but you could pull some very, very important information off of tools like this, right? If they're afraid of getting hurt when exercising, that's definitely a flag. The pain always means that my body is hurt. It's definitely a flag to some more brain-centered generation of pain. And this is that third kinesiophobia questionnaire, and they're quite similar. So one of these three would be good. This is a depression questionnaire. As you know, there are many out there, but this is one of many and should be administered by the PT if you know there's active depression or a history of depression. And then the trunk endurance tests. So these are important, and the methodology of doing this is important because the endurance is linked to back pain. So if they're scoring, I usually use like a 30-second cutoff. But if you do the flexion, which is on the right side of the screen, it really is just like a simple crunch. They really have to just clear the shoulder blades, but then hold that position. And PT then should be timing it and looking for endurance ability. And you'll see people start fatiguing, unfortunately, rather quickly if you do this enough. So it's an objective test, and it can rule out for the flexion and then rule in for the extension. Extension is probably even more important. So extension is the test on the left, again, having them just lie prone and clear the chest off of the mat and hold that as well. And again, just time it. So that's both sensitive and specific and simple. This is not, no equipment involved. A phone to time is really all that is required. And then the piles can be done with simple hand weights, ankle weights. Obviously, for lumbar, it's going to be a lift from the floor to 30 inches in height. You need to complete the 4 lifts in 20 seconds, and you begin with 5 pounds. And if they can do 4 lifts of 5 pounds in 20 seconds, they're allowed to rest, and then you add 5 pounds for each additional trial till they get a cutoff. You stop if they can't lift 4 lifts in 20 seconds, and or if their heart rate does go above their max, or 60% of their body weight is reached, or they do have poor lifting mechanics. So simple, could be done. Patient doesn't know the amount they're lifting either, so it's got to be hit. And then the walking is, like I said, a functional job requirement sometimes. So that'd be a great means of doing aerobic testing. Most clinics have a treadmill. If there is no walking required, I usually have the patient pick, and they might have access to certain equipment. So that'll tie into, you start obviously with the exercise program in the clinic, but you need to be doing it at home too. Me and Raphael were just talking earlier, and patients always ask me, the number one question I get is, what is the best exercise? And I have a very simple, straightforward answer: the one you do. So if they have access to something at home, choose that in the clinic to do the aerobic testing, and then the training afterwards. So that gives you your baseline of maybe time, their pace, and their heart rate. And it's definitely patient guided. They're going to come up possibly with their cutoff when they're first doing their testing, and then you build on it. It's very simple. I add time always at first to capture the endurance, and then you can pick up the pace accordingly. So the intervention, right? The plan of care first. That plan of care you get from the initial evaluation, usually at the end of the initial evaluation, should outline functional goals connected to the job, obviously. functional exercises related to job tasks or ADL. Obviously, lifting is a perfectly simple example of that, and you can use the Piles test as your intervention. So, same idea. And then that graded aerobic exercise from that baseline, add the time, then the pace is often what I do. To me, time is going to be of essence, right? The more time you spend during the aerobic workout, the better off you'll be. And once you hit something that's practical, 20, 30 minutes, then you can start increasing the pace. And then the trunk strengthening, extensors more than flexors should definitely be endurance related. It shouldn't be repetition. They should be holding those positions for at least 5 seconds, if not more. 5 seconds has an objective connection to improving strength. But if it's just 5 seconds, you need to then do repetitions. There is an endurance test for repetitions as well, but I find the time to be more practical. And if you ask me, probably a little bit more connected to exactly what the trunk has to do functionally is get proximal stability for distal mobility. Your best trunk strengthening exercises are a plank, a side plank, curls, and bird dogs. The bird dog is lifting in quadruped, opposite arm, opposite leg. So those should definitely be in the therapeutic exercises. Patient education should definitely be part of the overall plan of care. That patient education, as best you can, connect to ergonomics, and don't exclude home, even if it's a workers' compensation case. To me, sleep is the biggest issue. First and foremost, if they're not sleeping, everything else will break down. So the ergonomics of sleeping, extremely important. Pillow placement between the legs, on the side, hugging a pillow, using mattress that is adjustable if it is adjustable. Even going out thinking about getting a new mattress if it is too old. But sleep is extremely, extremely important. Don't sleep prone. Pain patient education, I'm going to go into a little bit more. It starts connecting that chronicity to brain generated pain rather than anatomical pain. Manual therapy, some PTs would say do not do anything passive. I would disagree partially. I would say if you wanted to do some soft tissue or even manipulations have been shown to help with chronic pain, but just 3 sessions, not every time with the manipulations. If you do have soft tissue work, I then teach the patient to do it on themselves. Tennis ball, using a Theracane, things of that nature. But to me, how I look at it, that it becomes a tool for pain reduction that is in their hands at any time. If I educate them with the soft tissue, obviously you really can't teach somebody to do a manip, although some people can do it. So I'll lean more towards the soft tissue and trigger point work, and it becomes something that reduces their stress because it becomes a tool that they can use to take control of the pain. And definitely keep in mind mindful exercise for patients. And this doesn't necessarily have to be expensive. It could be as simple as a YouTube video going through yoga or Pilates, and let the patient choose. Definitely important, I think, for sedentary jobs as well, to get their focus away from the pain and more towards maybe some normal experience with stretching and exercise and movement that they might not otherwise get through other means of exercise. And I always tell them it's not necessarily the methodology. At times, I find that it's the instructor who you might connect to more. And the beauty of YouTube is the instructor can be used daily, the same one, and they often post many different lessons, many of them free of charge. So mindful exercise is definitely a great tool to reduce chronic back pain. We know that to be a fact. So I've been saying this for years now. Exercise is the greatest pharmacological agent known to man. I know people say it's not a pharmacological agent. It's a change in physiology that definitely helps with every system in your body without, well, pharmacological agents have side effects. The beauty of exercise is there is little to no side effect unless done at a very, very high level. So really, really powerful, powerful tool. And anything is better than nothing, and a little bit more is better than anything. And keep going. And that's how I explain to patients. Just start moving, right? Aerobically, we're training them, and that will help reduce your pain, help you sleep better. Cortisol levels will go down, will reduce anxiety, inflammation, depression, nerve sensitivity, and insulin function. Name a drug that does all that. You can't. So beautiful thing. Well, maybe the GLPs, but we'll see. Trunk endurance, right? Definitely connected to a reduction of pain. So like we said, the planks, the bird dog, the curls, really should be, say, 4 exercises. You do a plank and a side plank. And those 4 done well and effectively will really serve as the trunk strengthening that they need. And then any functional exercises, say lifting, need to be graded, right? You could use that piles baseline and continue to grade upwards. It's very simple, free weights with squats. It can be done at home, but they maybe can use a box at home as well. Whatever sort of connects more functionally to the lifting requirements they have at work. If they say do have a toolbox that's probably going to be lifted one hand, so you might focus on that a little bit more. A log book is a great tool for these patients, giving them a specific schedule, and they log it into their book, making it practical, functional, and educating them on the importance of it is all done while they're doing these things in the clinic. So you often don't have extra time, but you can educate the patient while they're doing the exercises, and they will get, I think, pretty quick results if they really tune into pain scales and sleep and things of that nature. And even relaxation exercises with the mindfulness thought or meditation, again, all can be accessed through YouTube. And they need to understand how sleep plays such a big role, such a big role. So there are your top left plank, top right side plank, curl bottom right, and bird dog bottom left. Those 4 will serve everyone pretty well, even if they have a sedentary job. So this is what PTs often call this thought process of educating the patient. Is pain neuroscience, and it really derived from cognitive-based intervention, trying to reduce those maladaptive behaviors by having the patient understand that the pain experience is not anatomic, hence why many times imaging clouds and muddies the waters for them. It's so important to have them start to embrace and understand this. It's not easy. This is not easy. I think it does take a seasoned PT to do this well and right. The sooner they start, the sooner they get seasoned. It is something I am extremely comfortable with now, but it took me many a year. But if you do begin to use pain neuroscience, and there are a lot of tools out there on the web, APTA has some information that's patient centric to help with this process in writing. So you give those hands out to the patients. There is an app called Curable that is free for 6 weeks that was developed by the group I was certified with. And there are some other tools to help with this process. But this will result in decreasing their fear of pain and improving their physical performance, increasing pain thresholds during the exercise, which only helps them do the exercise, which will further increase pain thresholds, reduce their brain activity, and especially in the amygdala, where the pain generation often starts from the chronic pain presentation. Consider certified therapists. There's not a lot of PTs out there yet certified. Hopefully this continues to grow. I have a couple of grads that might be certified, but the Pain Reprocessing Therapy Institute is the one I was certified by. There's a NOIA group as well. They have a clinical directory. And then the Empowered Relief, which is out of Stanford University, also has a directory of people they have had certified. So that probably is a good place to go to for referral to specific PTs to help you understand they have the knowledge of chronicity of pain. Keep in mind your New York medical guidelines, right? The PT needs to be following them as well, having an active focus in your interventions. There are my references, and I will open the floor to any questions anybody has.